Ingrid.
Hello.
And welcome and thank you for having this discussion.
Thank you for inviting me.
About this discussion, it will also be put on the Kinetic Plus TV and probably on OMTRO vlog. So we will have two different channels that will host us and will transmit the things that we discussed today. The idea is to help people get good quality information from professionals because the amount of information that we have on Dr. Google and other doctors on www, the amount is good, but the information is not always very easy to digest or very easy to differentiate between good information and
not so
let's
good.
say not so good information. Can you tell us just a few things about yourself?
Yes, so I'm Ingrid Gedikoglou. I'm half Greek, half Norwegian. I'm neuromusculoskeletal physio, so it's what in the old days we called a manual therapist. And I'm one thesis away from also being an osteopath. And I've been working as a clinician for about 14 to 15 years. So mainly with people who are in pain or have some sort of musculoskeletal problem. I work with people with chronic pain, or as we call them, undissolved issues. And as a new osteopath, I'm also expanding my clinical experience into other fields. And I've been working for the past, say, 9 years as a teacher, either at the bachelor level or postgraduate. And just very tiny bit involved in research, but I wouldn't call myself a researcher, but yeah, I try to get involved into that as well.
So mainly you are focusing your energy in helping people, helping your patients, and while you have a little bit of free time, you teach? Or the little free time is dedicated to your family, yeah?
I think my hobby is learning. I love learning things.
All right.
So it makes it nice to have an extra motive, except for, as you said, wanting to help people. And teaching is also precious because physiotherapy has not always been the best. So it's good in creating a better, new version of physiotherapy by helping educate the young professionals.
Perfect, because this is also about education. We can have in mind both the physiotherapists that are looking at us and the patients that are always coming with the same questions, I think, everywhere. And because you are very, very skillful musculoskeletal therapist
thank you.
in the whole body, but especially you came here for the hand, and I know the shoulder.
Yeah, I teach the upper limb. Okay, I work with everything, but I teach the upper limb. Yeah.
Excellent. So, can you tell us which are the main issues or problems that patients come for you in Greece and probably also for us in Romania with the
upper limb. So the most frequent would be the shoulder, of course. The problem in Greece, and maybe this is elsewhere, because in Greece we don't have hand specialists, at least not as a recognized, established expertise.
It's the same here. So
it's the same.
Yeah.
So the problem is that often patients don't know they can go to physio for problems that affect their hand.
Right.
So it's not frequent that you will see someone coming for just pain there. They usually tend to bear with it or just, live with this.
About this, it's totally the same here, because they say, I have some pain, but I got used to it. Yeah. So it's there, right? I never thought about doing something more about it.
Which is funny, because when your shoulder hurts, you think, I must go to my physio.
Yeah, but the problem with the shoulder is that at one point, it will not allow you to wipe your behind, or it will not allow you to wash your armpit or wash your head. And that's a bigger impairment than just, okay, I have some pain here.
Yeah. It could be the case. And maybe doctors are not educated enough about what physiotherapists can do with the hand. So maybe they would refer more often if they knew that we can be quite helpful.
Right, so what can we do with the hand? What can we help in which directions can we help?
So there's nothing different here compared to the rest of the body. So depending on the country that you live in, you will either have a first contact physio, so that means that you can go straight to the physio without going to a doctor first, or you might have to go to a doctor, get the referral and the diagnosis, and then go to the physio. So the physio, depending on the country, will either do the diagnosis, or as we do in our countries, we do the assessment. So the rule that we always use in physiotherapy, as you very well know, is that we don't usually treat the condition, we treat the symptoms. So as with anything in the body, you want to establish what the patient or what the client complains about. It could be pain, it could be limited range of motion, it could be weird sounds. So then you thoroughly go through your examination. So you would do as, so if we speak to the physios now, to not the patients, we would do our passive examination, or so passive range of motion, active range of motion, palpation, all of that, observation, our special tests. And then we establish our treatment goals and our treatment plans. So the goal is, what are our problems? What do we want to fix? And how are we going to do this?
Right.
So it's just a matter of maintaining that structure that we have everywhere in the body for the hand. Sometimes
this is very useful for a physio to understand and to engage himself or herself into this.
So for patients.
What about for the patients? Because for the hand, they also came when the pain is disabilitating. It's creating a problem that's too much to bear, and the carpal tunnel syndrome is one of the worst in this direction. What can we advise our
So if I were a patient, I would want to see that my therapist is structured, that they're examining me or assessing me. So I wouldn't appreciate it if a physio just started, treating me without having assessed first. So I would like to see that there's a structure if I were a patient, and I would like to be part of the plan. And I would like to be informed what the plan is. So if I were a patient, I would like to hear, my plan is that we work for the next 2 weeks by trying to gain this movement that you don't have, or reduce this pain, and if we're successful by the end of 2 weeks, hopefully we'll be much closer to that goal.
I would go on the skin of the patient, on the role of the patient, and I said, okay, but I came to you to fix my problem. Why do we need to make a plan? Because I come to you, you are the specialist, please resolve my problem. Okay,
and I will, if I can, right? But it's good for the patient to also be in charge of his health. So it's what we have in the patient-centered care, that they need to be informed, they need to be active, they need to have self-efficacy. So when we have an active treatment rather than just a passive treatment, that has better outcomes, as we know from research. So as a patient, I would like to see someone who is structured and who has a plan. And I would like to see effects, of course.
Of course. Do you, I know what you think, but
I don't know what I think.
Is it important to have results session after session, or we need to wait? No, you do the treatments, I will wait 10 treatments, and after 10 treatments, maybe in 6 months I will be better.
Oh, that's the worst. That's the worst. No. Ideally, you want every time to have an effect. As I jokingly tell my patients, if you're worse, that's also good news. What I don't like is no change. No change means we were not effective enough, or our dosage was not enough, or we were playing in the entirely wrong field. So if someone is worse, it's not my intention, but it's actually good news. It just means we need to fine-tune it maybe. Provided they're not worse in an entirely new area, right? So yeah, you would never say, we'll do 10 sessions and then we see. So what I do personally is I explain to my patients how I expect them to come back next time. So I would say I expect that you should come back better next time. If you don't come back better, I think I might need to change my technique or what I'm doing.
All right, so you plant the seed. You play a little bit of inception there. So I expect for you to be a little bit better next time.
Yeah.
So please do your exercises.
There's a risk with that, though.
About this, do you prescribe exercises or not?
If they're necessary, of course. I might, let me just go back to that. Because you touched on something that's important. You want to raise realistic expectations, but you also want to explain that if, this is my prediction, but if you don't come back better, if you're worse, don't worry about that. And then I explain why one might get worse and how long it will last and what to do about that. So we make sure that we don't just set the expectation to you get better. We prepare for the worst as well.
Right.
So sometimes if I anticipate that someone is getting worse because I can see that they're irritable and they're getting aggravated, or maybe the circumstances in their life are aggravating the symptom, I might explain that I think you might be worse after today, so don't hesitate to take a paracetamol if you get your headache, or put some ice on, or call me. It should dissolve by tomorrow.
Right, so you explain your expectation, you explain your objective. Are the objectives of the patients also important, or not so much?
These are the only ones that matter.
Actually, yes, I totally agree.
You ask them why they're doing their physio.
So it's not for your own ego?
It's for my pocket. Yeah. No, of course, it's the patient is the one who sets the objectives. You ask them, how can I help you? So other people will tell you, oh, I don't care about this pain. This pain I'm used to. I just want you to fix this.
Yeah.
So then you don't go treating this. You do what the client asks you to do. But sometimes, you want to put priorities to your objectives. What we can achieve by this week, what we would like to achieve by this month, and so on.
A funny story about objectives. Because you discuss the objectives, I discuss the objective with my patients, and I ask them, okay, what would you like to improve? What would you like to do if you get better? And I try to be very specific. And one young lady, she said, I really would like to play badminton after I finish the treatment, because before I played very good, but because of the pain, I cannot do it. And we started the treatment. She felt a lot better. She felt that she's in a good direction. And she came to me and she said, look, about my personal objective, I think I want to change it.
What was it?
I really don't want to play because, okay, I was good, but I don't love it so much. And I want to change it. And for the moment, I'm very good as I am. So I think I will stop the sessions because my new objective is just to be good. I don't care about the badminton so much.
I don't know whether that's wonderful or horrible.
I don't know, but she was reassessing her initial objective, and she came and said, "Look, I know I told you this, but
I'm happy now.
I'm really happy now."
And I'm sure this happened because you were open to discussion. You were asking her. If we don't it's not only important to do so in the first assessment. I'm sure that you kept asking her and involving her in the dialogues. Hence, she had the freedom to express this to you.
It's very important because at the end of the day, we are doing all that we are doing for the patients. So.
Yes, and maybe this has not reached all countries yet, but it used to be that the epicenter was the doctor or the therapist, and everything evolved around the doctor, right, or us. Yeah. So now it's the patient who is in the center of care. So it's all about the patient.
Of course, and it's about the patient getting the best of the education and best of the knowledge that's on the market, because things evolve. Just a few years ago, the concentration of therapies was for passive therapies. In Romania, we still have a big issue with the number 10. The magical number 10.
I think we have this in Greece too.
But it's because of the national system. It's not something bad or good, but it's something that just remain with the people, that you only need 10 sessions, and 10 sessions you should get better. They don't care if you are a neurological patient, a chronic patient.
So then again you would try to explain this. Almost all people ask, how many sessions do you think it will take? Which is a difficult answer. And when you're not very experienced, it's even more difficult to answer. I always tell them that I need to see a bit of how your body responds, what kind of dialogue I'm having with your body, and then I'll be able to tell you more. So maybe give me 1 or 2 sessions, and then I'll let you know what I think. So
I think it's fair.
Yeah.
About the problem of the patient and objective, I'm always underlining that, look, you came for help. I will do my best in helping, but at the end of the day, the problem, it's yours. You are going to take it with you back home. So if you are not getting yourself involved in this and you are not setting your objectives correctly, it cannot be my full responsibility.
That's a good approach.
Yep.
Indeed.
So, because we can help, we can guide, but we can not do exercise
for them. And a good way to build on that is when you ask them about what they think is wrong with themselves, you can also ask them how they think this will be treated. So what do you think is needed for you to get better? So if they say, oh, I'm just going to lie down, you fix me, then you know you need to work on this kind of thinking before you actually start treating.
And sometimes because of this, our intervention may be in a multidisciplinary team. We can get a little bit of involvement from other colleagues from other fields like psychologists or occupational therapists and so on.
Personal trainers.
Because things are complex, and working with people is even more complex because everyone is a little bit different, a lot more different.
And health itself is multifactorial.
Exactly. And we cannot treat all conditions the same, and we cannot help all the people in the same amount of percentage.
Yes, which brings us back to the question I didn't answer before about whether I prescribe exercises. So when we are being evidence-based, we know that exercise is very often a very good treatment. So either we would prescribe exercise because we know from research that it's effective, as in, for example, tendinopathies, or maybe we just want to get someone generally more active. So change of lifestyle. Right? Or maybe we can use it as a means to get someone from being a very passive recipient into becoming more active, and maybe then more
involved in the process.
Exactly. Yes.
And going back to the hand, and then I think we can wrap it up.
We didn't end up talking too much about the hand.
But
it's not so different. It's just everything. The anatomy is scary, but it's kind of
when we talk about pain, and right now the emphasis is on the low back pain. We only have 5 bones there, and they produce a lot of pain. Five vertebrae. Okay, if you want to talk about,
let's say the area has a lot of pain.
The area can produce a lot of pain because there are a lot of structures involved, not only the bones. But in the end, we have the carpus, the metacarpus, the phalanx. We have a lot of bones crowded together, which receive a lot of forces because every time you put all the weight of your body on the hand, you create a lot of.
But that's what it was designed for.
Yeah, I know. Exactly.
I'm telling the patients in the audience.
And the function and the design of each of our body parts, it's very important to build up the whole rehabilitation program. And when you have a structure that's designed to lift up the whole body and support it, and you only keep it passive and don't do anything, it will not help too much.
Oh, absolutely not. It will actually probably create a lot of damage. So that's the worst kind of advice, unless it's specifically instructed by the surgeon in order to allow healing of a specific structure maybe. We always prefer movement.
Because
we don't want immobilized people.
okay. So what's your final advice for people that have pain in the upper limb?
Do something about it.
How much can we wait until we need to do something about it?
So this is my rule, okay? When a client calls me on the phone and say, Ingrid, I'm in pain, I ask, how long have you had the pain for? Provided it's not super acute and like severe pain, okay? Oh, it's just a nag. I've had it for 2 days.
1 year.
2 days, yeah. Wait another 2 years. So if they say I've had it for 2 days, I might say, provided it's not an athlete or someone who's performing, I'll say, give it another 2 days or 3. And if it's not gone by the end of this week, call me and make an appointment. So you need to know, to answer this, you need to kind of know the prognosis of things, of conditions. So if somebody calls me and says, oh, I've had it for 3 months, I would say book an appointment tomorrow. If it's not gone, it needs help.
Yeah. Thank you very much for
Thank
today.
You. I hope this has been helpful for anyone listening. Thank you for inviting me.
Let's hope that it will reach the people that need it. And see you again very soon.
Yes, I hope so.
Thank you.